Jim, thank you for having me. I certainly learned a lot from Dr. Tassiopoulos and Dr. Schneider. Great talk, great to be back. I'm going to talk about my algorithm and what I think about when I'm considering performing open aneurysm repair in the endovascular era. Disclosures. As far as the couple of words about epidemiology, almost 200 new cases of AAA at the United States every year annually, and as far as the death rate, anything from 10,000 to 15,000. So these are the numbers that I usually think about when you're thinking about AAA and the impact that it has in society. People who are greater than 55 years old, men, almost 1% of them have abdominal aortic aneurysm. Couple of slides about the trends with the advent of endovascular AAA repair in early 2000. We saw a shift in AAA treatment modality, which shifted from open to endovascular throughout the years. Geographically, you can see it in the United States, and as time goes by, we see less and less open aneurysm repair. This trend is global. This graph shows the trend of AAA repair in Canada. 80% of AAA in Canada happen endovascular. Interestingly, the size criteria is a little different. In Canadian, they tend to operate on a larger aneurysm, but certainly the number of open AAA are less and less common even in Canada, and this has been seen in the rest of the world. Then as far as the mortality with AAA, we see that the mortality goes down over years. This has been seen globally, although it's a little different in different countries, but we see decreased mortality. And interestingly, this mortality reduction has linear relationship with medical management more so than our endovascular management. This has been shown in this circulation paper, and that has actually a very linear relationship with blood pressure control, cholesterol, smoking, and BMI. Factors that we should consider when you're thinking of AAA repair. The first thing is what is the aortic rupture risk? What is the risk that patient has from surveillance of this AAA? And what are the operative risks? These operative risks could be patient factors, comorbidities, COPD, CHF, those type of things, or surgeon or hospital factors. And also, what are the anatomical limitation? And most importantly, what's the patient life expectancy and preference? So these are the factors that I think about when I'm thinking about open AAA versus endovascular. The rupture risk is well established in literature. We know aneurysm greater than 5.5 centimeter have increased risk of rupture. Anything from 5 to 10% after 5.5 centimeter, but the major risk is actually greater than 7%. Aneurysm greater than 7% have almost 30% risk per year of rupture. And we have seen that these rupture risks actually decreased over years recently. However, this is still we recommend aneurysm repair for men greater than 5.5 and women greater than 5 centimeter. When I look at the rupture risk, I like to look at it low, average, and high. Patients who have greater than 6 centimeter diameter, or they have smoker, COPD, and have family risk, and also have poor control, hypertension, and the shape is eccentric, they are higher risk as opposed to diameter less than 5, fusiform, normal blood pressure. So you can sort of gauge the rupture risk when you're thinking about repairing somebody's aneurysm. We know from ADAM trial and UK trial that a small aneurysm less than 5.5 do not pose danger, and open repair of small aneurysm did not increase the survival rate. Similarly, for endovascular, we saw the same thing, and no survival benefit for endovascular for EVAR in the small EVAR trials. The operative, now we talk about rupture risk, and then you have to know what's the operative mortality. We know that in endovascular era, the endovascular for asymptomatic endovascular aneurysm repair is almost 1% risk, opposed to probably around 3 to 4% for open. Obviously, if it's rupture, it's probably around 22% for endovascular and probably around 30% for open. So these are the operative risks that patient has. And then what are the predictors of operative mortality, comorbidity? These are the main ones: heart failure, coronary artery disease, kidney failure, COPD. Age is very important. Advanced age increases the mortality, and the diameter of the aorta is also important. And many reports has shown that hospital and surgeon volume actually affects the mortality. Again, there are different mortality risk prediction models that I'm not go over, but you can use that to assess the preoperative mortality risk stratification for yourself. And then there are anatomical limitations for EVAR. The major one is hostile neck. When they are short and wide neck and angulated neck, when there's thrombus in the neck and the neck is calcified. So these are the factors that I think about, and usually I consider open AAA if there's anatomical limitation for EVAR with the hostile neck, with multiple renal arteries, when there's inadequate access, aneurysm complex, and also to treatment of infected aneurysm or graft, or failed EVAR, or some special cases such as horseshoe kidney inflammatory or congenital. A couple of cases, this was an infected graft that presented to us with symptoms of abdominal pain, and there was air around the graft. It's important to do these cases early in the day. Suprarenal control is important. My go-to for reconstruction in inline reconstruction with revamping soak. Again, these cases are difficult cases. You have to make sure that you have enough help at your disposal. This is another young male with aneurysm and an access to renal artery that I chose to do open with reimplantation. Again, you have to do, different people have different setups. I like OmniReject retractor, I use Cell Saver, and I make sure that I have everything at my disposal when I'm doing these cases. This is a 80-year-old male with a large, with a large angulated neck, and obviously this was not a very hostile neck, not really amenable to endovascular, which we treated with a tube graft. So what is the, when you're comparing open and EVAR, what is the comparisons of mortality and survival? We know that from randomized trial that perioperative mortality is lower with EVAR. However, this perioperative mortality is not durable, and it sort of loses its significance after 2 years. Similarly, in this Mayo Clinic report, it's shown that actually open repair has better survival after 2-3 years. And this has been shown in multiple reports. The recent article from JVS that I really like, they looked at EVAR versus open based on age, and what they found is that in patients that are less than 65 years old, open repair actually is superior as opposed to patients who are 80 years old and older. And interestingly, when they looked at it, if patients who are less than 65 and do not have CAD and do not have CHF and do not have chronic kidney disease, they did way better open compared to endovascular.